Welcome to this Q&A session for the CMAA certification exam. These are real exam-style questions. We don't just reveal answers, we break down the reasoning behind every one. This video covers questions on delivery models, EHR and downtime, Medicare and Medicaid verification, write-offs and medical coding sets, consent, court orders and HIPAA, documentation and readback verification. Don't forget, our website offers free study guides and practice questions to help you pass your CMAA exam with confidence. It's a great way to prepare effectively. You'll find the link right in the description below, so be sure to check it out and start studying smarter, not harder. Alright, let's dive in. Question 1. A regional clinic group joins a Medicare Shared Savings Program contract that pays bonuses if quality benchmarks are met while keeping total costs below a target for an attributed population over the contract year. Which delivery model best fits this overall contracting arrangement? Your options are A. Patient-centered medical home, B. Federally qualified health center, C. Accountable care organization, D. Collaborative care model. Which one is it? Pause the video if you need more time. The correct answer is C. Accountable care organization. C is correct because an accountable care organization is a network that voluntarily contracts under programs such as MESSP, sharing savings or losses when quality benchmarks are met, while total cost stays below a benchmark target. A is wrong, because a patient-centered medical home is recognized through accreditors like NCQA for primary care delivery and team-based coordination, but the model is not defined by a Medicare shared savings contracting arrangement. B is wrong because a federally qualified health center serves underserved populations using a sliding fee scale and federal grant support, which is unrelated to a shared savings contracting structure for cost and quality. D is wrong because the collaborative care model embeds behavioral health services into primary care using a registry-based care manager and consulting psychiatrist, not a Medicare shared savings cost and quality contracting structure. An accountable care organization is a voluntary network of doctors, hospitals, and clinicians that contracts together to take responsibility for the cost and quality of care for a defined group of patients. Most often this happens through the Medicare Shared Savings Program. This model exists because traditional fee-for-service medicine pays for volume rather than results. By tying the whole network's bonus to outcomes and total cost, an ACO gives every clinician a financial reason to coordinate care and prevent unnecessary admissions. Mechanically, an ACO tracks attributed lives and monitors quality measures like diabetes control and screening rates. Care coordinators reach out to high-risk patients. Transitions of care nurses follow patients home, and analytics teams flag rising risk before it becomes a crisis. Remember, an ACO is a contracting arrangement, not a clinical delivery model. A patient-centered medical home is an accreditation for primary care delivery. A federally qualified health center is a clinic type funded by federal grants. And collaborative care is a behavioral health workflow, not a population-level contract. On exam day, watch for the phrases shared savings, attributed population, total cost of care, and Medicare Shared Savings Program. Anchored language about a voluntary network contracting for cost and quality almost always points to an accountable care organization. Question 2. A practice activates downtime procedures during an unplanned EHR outage, switching to paper appointment books, intake forms, and progress notes until the system returns. Which underlying purpose best fits the downtime toolkit during this kind of outage at the practice? Your options are A. Maintain safe continuous operations on paper, B. Force every patient to leave, C. Cancel future weeks unilaterally. D. Inform marketing about issues. Take a second. Which answer would you pick? The correct answer is A. Maintain safe, continuous operations on paper. A is correct because downtime toolkits maintain safe, continuous operations on paper, including appointment books, intake forms, progress notes, prescription pads, lab requisitions, and education handouts until the system returns and data are back entered. B is wrong because downtime procedures do not force every patient to leave. They support continued operations through paper alternatives and back entry once systems are restored to working order at the practice. C is wrong because downtime procedures do not cancel future weeks unilaterally. They support short-term operations during an outage rather than altering long-term scheduling for the practice's calendar going forward. D is wrong because informing marketing about outages is not the underlying purpose of downtime procedures, which focus on safe continuous operations rather than communications with the marketing function at the practice. When the electronic health record goes dark, practices don't shut their doors. They switch to downtime procedures, a documented set of paper and manual workflows that keep care moving until the system returns. The toolkit lives in a binder at every workstation. It includes paper appointment sheets, intake forms, progress note templates, lab requisitions, prescription pads, and patient education handouts. Everything needed to keep functioning without the computer. Picture a Tuesday morning outage. The front desk grabs the printed schedule and logs walk-ins on a runner sheet, while clinical staff chart on paper progress notes and medication reconciliation sheets. When the system returns, staff back enter everything into the electronic record. Don't confuse this with related terms. Disaster recovery is the broader IT process of restoring systems after something like a server crash or cyber attack. Business continuity is broader still, covering the entire organization through events like building loss or a pandemic. Downtime procedures are the narrow clinical and administrative response during the outage itself. The exam trap is picking the extreme option, like cancelling appointments or sending patients home. Downtime procedures exist, so no patient is ever turned away. The real disruption happens later, when staff back enter everything into the chart. Question 3. A team backs up the day's schedule by printing a copy each morning and keeping a runner sheet for new bookings during downtime. After the system returns, the CMAA back enters all paper data into the EHR. Which underlying principle best fits this back entry step in the documented workflow? Your options are: A. Discard paper to save filing time. B. Only re-enter cancellations later. C. Preserve verbal communications only. D. Preserve a complete electronic record. Before I reveal it, which one do you think is right? The correct answer is D. Preserve a complete electronic record. D is correct because back-entering paper data preserves a complete electronic record after downtime, supports continuity for future visits and reporting, and reconciles the practice's billing capture with the actual visits delivered during the outage. A is wrong because discarding the paper after back entry is a separate decision per policy. The principle behind back entry itself is preserving a complete electronic record rather than reducing filing volume in the office. B is wrong because only re-entering cancellations leaves new bookings, completed visits, and other data missing from the EHR, which fragments the record and disrupts both clinical continuity and downstream billing accuracy. C is wrong because preserving verbal communications only would lose the booking, intake, and clinical content captured on paper, which is exactly what back entry is designed to bring forward into the electronic record. When the system outage forces a practice onto paper, Back entry is the disciplined process of bringing every one of those paper records into the electronic health record once the system returns. The paper note is only a backup, not a permanent destination. If a visit stays trapped on paper, the next clinician sees a gap, missed medications, unknown allergies, and an unfiled claim. Mechanically, back entry mirrors the original paper trail. Schedule entries go in first, then demographics, then progress notes, then prescriptions, then charges, and finally reconciliation checks paper logs against the electronic record to catch anything missed. Wrong answers tempt with shortcuts, discarding paper, entering only some item types, or just scanning notes as images, but scanned images aren't searchable or usable for clinical decisions, and audit logs only track access, not the content itself. Picture 18 paper visits after a 4-hour outage. Staff work through schedule, demographics, notes, and charges until every visit lives electronically, so the next clinician sees a complete history, not a folder of paper. Question 4. A CMAA registers a minor whose divorced parents disagree about consent. The mother brings a court order limiting the father's access. The CMAA must protect the patient and follow the order while remaining professional with both parents. Which response best matches policy in this kind of situation? Your options are: A. Side openly with the mother. B. Honor the court order strictly. C. Discuss parental conflict with child. D. Disclose appointments to either parent. What's your answer? Commit to one before I continue. The correct answer is B. Honor the court order strictly. B is correct because court orders such as restraining or custody orders must be honored strictly, including not disclosing any information to the restrained party, while interpersonal disputes between parents are eroded to administration or social work. A is wrong because siding openly with one parent compromises professional neutrality and can complicate care for the minor. The right path is to follow the court order and route the dispute to leadership without taking sides. C is wrong because discussing parental conflict with the child is harmful to the minor and inappropriate at the front desk. The CMAA's job is to protect the child from adult conflict during the visit. D is wrong because disclosing appointments to either parent without checking the order can violate the limits the court has placed. Appointment information is part of the protected record that must follow the legal restrictions. When a court order limits a parent's access to a child's medical information, that order takes precedence over any disagreement happening at the front desk. Staff must honor it strictly, no matter what either parent says or requests. Practically, the chart carries a clear flag showing any current court order, and staff check for it before check-in or phone disclosure. If a restrained parent calls, the CMAA declines to confirm or deny the child's presence and routes the question to administration, never negotiating consent disputes at the desk. The mechanism is simple. A copy of the court order lives in the chart with a visible flag, so front desk staff can check it before any information is shared. Exam writers test whether students side with the parent holding the order or try to mediate between the two adults. Both are wrong. Neutrality and referral to leadership, social work, or legal counsel are the only correct responses. Whenever you see court order, custody, or restraining order paired with parental conflict, the answer is always the same. Follow the order strictly and let administration handle the rest. Question 5. A clinic verifies Medicaid coverage at the start of every month because eligibility changes more frequently than Medicare. The CMAA recognizes the underlying reason for the cadence. Which underlying reason best fits this monthly verification cadence for Medicaid at the practice? Your options are: A. Medicaid never changes once enrolled. B. Medicaid bills only quarterly. C. Medicaid eligibility changes month to month. D. Medicaid is voluntary every year. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Medicaid eligibility changes month to month. C is correct because Medicaid eligibility can change month to month based on income and program category. So verification at the start of each month catches changes that affect coverage and prevents denials for patients who remain enrolled. A is wrong because Medicaid eligibility is not stable once enrolled. Renewal and category changes can affect coverage, which is precisely why monthly verification is the standard cadence for the program at most practices. B is wrong because Medicaid does not bill only quarterly. Claims follow normal cycles, but eligibility verification is specifically tied to the monthly changes in coverage rather than to a quarterly billing schedule. D is wrong because Medicaid is not voluntary every year in the way the option suggests. Verification is monthly because of routine eligibility changes rather than annual voluntary enrollment periods. Medicaid eligibility is verified at the start of every month because coverage itself shifts month to month with income, household changes, and employment status. Unlike Medicare, which stays stable once a beneficiary enrolls, Medicaid moves with the patient's life. This happens because Medicaid is means-tested and category-based. Each state sets its own income thresholds, asset limits, and eligibility categories like pregnant women, children, or the disabled. Renewals and redeterminations run on state-specific schedules that commonly trigger month-to-month coverage changes. Mechanically, front desk or centralized eligibility staff run a real-time query through the state Medicaid portal on the first of every month, which returns coverage status, plan name, copay amounts, and service limitations. That result gets documented in the chart so billing can match claims to confirmed eligibility. The cadence ties directly to how coverage actually behaves, not billing rules. Medicare is checked less often because it stays stable. Commercial plans are checked at intake and on changes. And CHIP often mirrors Medicaid's monthly pattern. Watch for wrong answers claiming Medicaid never changes or bills quarterly. Medicaid is monthly because eligibility itself moves monthly, catching lapses and plan switches before claims ever go out. Question 6. A self-pay patient receives a written estimate of expected charges for a planned colonoscopy under federal protections from surprise billing. The CMAA recognizes the underlying federal protection. Which protection best fits this estimate? Distinct from the OSHA exposure framework and the Stark referral framework today? Your options are A. No Surprises Act Good Faith Estimate. B. OSHA Exposure Control Plan Estimate. C. Stark Referral Disclosure Document. D. Universal Protocol Surgical Checklist. Which would you go with? Lock it in before the reveal. The correct answer is A. No Surprises Act Good Faith Estimate. A is correct because the No Surprises Act requires a good faith estimate of expected charges for self-pay or uninsured patients before scheduled services, with dispute resolution available if charges exceed the estimate by $400. B is wrong because the OSHA Exposure Control Plan covers workplace blood-borne pathogen protections rather than patient billing estimates, so it does not match the federal estimate the patient is receiving here. C is wrong because Stark Referral Disclosure addresses physician self-referral relationships rather than patient billing estimates, so it does not match the federal estimate the patient is receiving in this scenario today. D is wrong because the Universal Protocol Surgical Checklist supports pre-procedure surgical safety rather than patient billing estimates, so it does not match the federal protection this patient is benefiting from today. The No Surprises Act effective in 2022, created federal protections against surprise medical bills, including a requirement that providers give self-pay and uninsured patients a good faith estimate of expected charges before scheduled services. This law exists because patients, especially self-pay and uninsured ones, had no way to anticipate charges or shop around. So the good faith estimate gives them a clear, upfront document to compare against actual bills later. Mechanically, the document lists itemized expected charges, diagnosis codes, and service codes, plus a clear statement that the figure is only an estimate, delivered in writing within 1 to 3 business days, depending on how far out the service is scheduled. Picture a self-pay patient scheduling a colonoscopy. Within 1 business day, the estimate lists the facility fee, professional fee, anesthesia fee, and pathology fee, totaling $1,800, emailed to the patient and saved in the chart. Don't confuse this with other frameworks. OSHA's Exposure Control Plan covers workplace safety, Stark Law governs physician self-referral, the Universal Protocol handles surgical safety checks, and hospital price transparency postings are separate documents entirely. If actual charges exceed the estimate by $400 or more, the patient can invoke the federal dispute resolution process. Question 7. A patient presents with periumbilical pain that has migrated to the right lower quadrant over 12 hours, plus low-grade fever, nausea, and decreased appetite. The CMAA recognizes the migration pattern as a classic teaching point. Which condition does this clinical picture most directly suggest to a clinician? Your options are A. Cholelithiasis episode, B. Sigmoid diverticulitis, C. Reflux esophagitis, D. Acute appendicitis. Don't overthink it. Which one feels right? The correct answer is D. Acute appendicitis. D is correct because acute appendicitis classically presents with periumbilical pain that migrates to the right lower quadrant along with low-grade fever, nausea, and anorexia, prompting urgent surgical evaluation rather than routine outpatient management. A is wrong because cholelithiasis episodes typically cause right upper quadrant pain after fatty meals rather than periumbilical pain that migrates to the right lower quadrant with the systemic signs described in the scenario. B is wrong because sigmoid diverticulitis classically causes left lower quadrant pain with fever and altered bowel habits, which does not match the right-sided migration pattern described in this patient's clinical presentation. C is wrong because reflux esophagitis produces heartburn, regurgitation, and a sour taste rather than the migrating abdominal pain pattern with systemic features described here, and surgical referral is not the typical pathway. Appendicitis has a signature pattern that every exam writer loves to test: pain that starts in one place and moves to another over several hours. Early inflammation irritates visceral nerves from the mid-gut, so the brain perceives vague pain near the belly button. As inflammation spreads to the parietal peritoneum, somatic fibers pinpoint sharper pain to McBurney's point in the right lower quadrant. The exam fingerprint is periumbilical pain that migrates to the right lower quadrant, paired with low-grade fever, nausea, and anorexia, plus tenderness at McBurney's point and an elevated white count on labs. Don't confuse it with lookalikes. Cholelithiasis causes right upper quadrant pain after fatty meals. Sigmoid diverticulitis causes left lower quadrant pain. Reflux esophagitis causes heartburn without migration. And PID or ovarian torsion can mimic right lower quadrant patterns. Whenever a stem describes pain moving from the navel to the right lower quadrant alongside fever and nausea, recognize the fingerprint and escalate without delay. Question 8. A provider asks a staff member to sign for delivery of a medication the staff member is not licensed to handle and to document its administration. The CMA recognizes the scope issue. Which response best fits accepted practice for this out-of-scope request? Your options are A. Sign and document anyway. B. Hide the issue from the manager. C. Refuse politely, route to qualified staff. D. Document a different drug instead. Got a guess? Lock it in. The correct answer is C. Refuse politely, route to qualified staff. C is correct because refusing politely and routing the task to qualified staff respects the CMAA's scope of practice, protects patient safety, and avoids the legal and clinical risk created by acting outside the documented role. A is wrong because signing and documenting medication outside scope creates clinical and legal risk, can falsify the record, and exposes the staff member, the practice, and the patient to harm and enforcement action. B is wrong because hiding the issue from the manager allows an unsafe practice pattern to continue, conflicts with professional ethics, and undermines the chain of command designed to address scope and safety concerns. D is wrong because documenting a different drug falsifies the medical record, which is itself a serious legal and ethical violation, regardless of the original request that prompted the medication handling question to the staff member. Scope of practice defines what a credentialed staff member is trained and licensed to do, and just as importantly, what they must not do. A CMAA scope is administrative and clerical, registration, scheduling, phones, billing, and documentation. It never includes clinical tasks like receiving or administering medications, drawing blood, or interpreting labs. Stepping outside that scope risks harm to patients, the staff member, and the practice. Scope is set by 4 aligned sources: state law, professional credential, employer job description, and practice policy. When all 4 agree a task is out of scope, that task simply does not get done by that staff member, no matter who is asking. Picture a CMAA handed a clipboard mid-shift and asked to sign for a controlled substance and document its administration. The correct response is a polite refusal, rerouting the task to the medical assistant or nurse on duty, and making sure the chart accurately reflects who actually handled it. On exam day, watch for out-of-scope requests dressed up as urgent favors. The right answer is always polite refusal and rerouting to qualified staff. Never compliance and never confrontation. Question 9. A Medicare patient hands the CMAA a card showing a private insurer's logo and a Medicare Advantage plan name that replaces the original red, white, and blue Medicare card. Which billing path best fits this Medicare Advantage card at the practice today? Your options are A. Bill the Medicare Advantage plan directly. B. Bill original Medicare without the MA plan. C. Refuse to bill any plan at all. D. Bill only the patient out of pocket. Which one is it? Pause the video if you need more time. The correct answer is A. Bill the Medicare Advantage plan directly. A is correct because Medicare Advantage replaces original Medicare for the patient, so the practice bills the Medicare Advantage plan directly using the plan's identifier rather than submitting claims to original Medicare for these patients. B is wrong because billing original Medicare instead of the Medicare Advantage plan creates denials and rework, since the patient has elected the private plan to provide their Medicare benefits during this enrollment year. C is wrong because refusing to bill any plan is not appropriate when the patient has active Medicare Advantage coverage, which the practice should bill in line with the participation status and signed assignment of benefits. D is wrong because billing only the patient out of pocket bypasses the active Medicare Advantage coverage that the patient has elected, which conflicts with the standard billing approach for patients with this kind of plan. Medicare Advantage, or Part C, is a private plan that fully replaces original Medicare for the patient who enrolls, bundling Part A, Part B, and often Part D drug coverage with extras like vision or dental. Think of Medicare Advantage as swapping your entire policy rather than layering on extra coverage. The private plan takes over as primary, so the practice bills that plan directly using the identifier on the Medicare Advantage card, not original Medicare. At check-in, the CMAA sees a card with a private insurer logo and the words Medicare Advantage Plan, updates the system to mark that plan as primary, removes original Medicare, and verifies coverage through the plan's portal before the claim is sent. Don't confuse this with Medigap, which supplements original Medicare billed first, or Medicaid as secondary payer for duly eligible patients, where Medicare stays primary. Medicare Advantage is different because it replaces the primary payer entirely, so billing both or billing neither is always wrong. Whenever you see a Medicare Advantage or Part C card, that private plan is the only payer, so send the claim straight there. Question 10. A staff member positions a patient-facing monitor at the registration desk so that arriving patients in the lobby cannot easily read the screen. The compliance officer praises the practice. Which underlying safeguard category best fits this physical arrangement of equipment in the front desk environment? Your options are administrative training requirement, B, technical encryption requirement, C, marketing strategy decision, D, physical workstation control. Take a second. Which answer would you pick? The correct answer is D, physical workstation control. D is correct because physical workstation controls include placement away from public view and the use of screen visors, which protect identifiable information from incidental viewing by people in lobby and waiting areas around the desk. A is wrong because administrative training is a different category that focuses on workforce education, sanctions, and risk analysis rather than the physical placement of a monitor at the registration desk in the lobby. B is wrong because technical encryption protects data through cryptographic controls in the system rather than the physical positioning of a monitor, which is what the safeguard described in this scenario actually addresses. C is wrong because marketing strategy concerns customer acquisition and brand messaging rather than safeguard categories, so it does not match the physical workstation control that the compliance officer is praising at the desk. HIPAA's security rule includes physical safeguards, which protect the tangible placement and access of equipment, workstations, and facilities that handle protected health information. Monitor placement at a registration desk is a classic example. A patient sitting in the lobby who can read the registration screen learns the names, birth dates, diagnoses, and insurance details of everyone checked in that morning. That's a breach by line of sight, and the security rule treats physical arrangements as seriously as passwords or encryption. Physical workstation controls include placing monitors away from public view, using privacy screen filters, set in automatic screen locks, locking workstations in non-public areas, securely disposing of printouts, and requiring badge access to sensitive equipment areas. Picture a compliance officer walking the lobby and noticing the registration monitor faces the seating area, readable from 12 feet away. The staff repositions the monitor at an angle, adds a privacy filter, and lowers the brightness, and the next walkthrough confirms nothing is legible from the lobby. The exam tests precise mapping. Administrative safeguards cover training and sanctions. Technical safeguards cover encryption and audit logs inside software, and the privacy rule governs permitted uses and disclosures. Physical safeguards alone cover the tangible environment, exactly where monitor placement at the front desk belongs. Question 11. A scheduler considers booking a routine follow-up into a slot that the template holds until the day of for urgent visits. The CMAA reviews expectations for that slot. Which response best fits accepted practice for booking decisions about a held same-day slot? Your options are: A. Book the routine into held slot now. B. Cancel the held slot to prevent abuse. C. Avoid stealing held slots before release. D. Move the patient to a different specialty. Before I reveal it, which one do you think is right? The correct answer is C. Avoid stealing held slots before release. C is correct because avoiding the use of held same-day slots for routine bookings before they're held until time keeps urgent capacity available, which is the entire point of templating a portion of the day for that kind of demand. Is wrong because booking the routine into a held same-day slot before release defeats the purpose of holding capacity for urgent access and can leave acute callers without an appointment when they call later. B is wrong because cancelling the held slot would shrink urgent capacity rather than protect it, which conflicts with the template designed to support same-day access during the practice's regular operating hours. D is wrong because moving the patient to a different specialty is a separate decision driven by clinical reason rather than by a desire to fit a routine visit into a same-day urgent slot. Held same-day slots are time blocks kept open on the schedule until a defined release point, reserved for urgent or acute callers. They're a capacity management tool, not an administrative quirk. This exists because demand arrives in two streams: routine demand that's plannable weeks ahead, and acute demand that shows up the same day. If the whole schedule fills with routine bookings, an acute caller ends up in urgent care or the ER for something the practice could have handled. Holding capacity is the release valve for that acute stream. Mechanically, the template flags certain slots as held, often invisible to routine booking until 8 or 9 that morning. Acute calls get triaged directly into them. At release time, anything unfilled opens up so capacity isn't wasted. Don't confuse this with open access scheduling, which keeps the whole day open until day of. Block scheduling, which reserves time for specific service types, or wave scheduling, which just describes arrival patterns. The exam nuance is restraint. Filling held slots early breaks the system, and cancelling them shrinks urgent capacity. The correct behavior is simply to leave them alone until release time, even when a routine patient is tempting you to do otherwise. Question 12. A CMAA accidentally enters the wrong insurance plan into the registration screen and the claim later denies. The supervisor coaches accountability rather than blame. Which response best reflects accountable, professional behavior consistent with the practice's expectations after a documented mistake at the registration desk? Your options are: A. Blame the patient for confusing answers. B. Acknowledge the error and remedy. C. Hide the error from the manager. D. Wait until next year to fix. What's your answer? Commit to one before I continue. The correct answer is B. Acknowledge the error and remedy. B is correct because acknowledging the error, fixing the registration, notifying billing, and adjusting the workflow to prevent a repeat reflects accountable professional behavior, which protects the patient, the practice, and the CMAA's professional standing over time. A is wrong because blaming the patient deflects responsibility, can damage the relationships, and avoids the corrective steps that fix the claim and prevent a similar mistake on the next visit at the practice. C is wrong because hiding the error from the manager violates the trust that makes corrective workflow possible, and it allows downstream billing problems to grow until they become more difficult to resolve cleanly. D is wrong because waiting until next year to fix the issue ignores timely filing rules and harms the practice financially, while also failing to address the workflow gap that allowed the original error to happen. Accountability means owning a mistake and following through with the corrective steps that fix it and prevent it from happening again. It is not self-punishment or fear of consequences. It's acknowledging the error and acting on it. Healthcare officers run on chains of dependent steps, so a wrong insurance plan entered at registration produces a denied claim weeks later, then a patient-facing balance, then collection work. Catching the error early breaks the chain before it becomes expensive. Accountability follows a simple sequence: confirm what happened, take corrective action including notifying anyone affected, then document the fix and reflect on what allowed the mistake so the workflow can be tightened. Supervisors who coach this rather than blame create a culture where staff surface problems early. Picture a CMAA who discovers a Blue Cross patient was registered with United Health 3 weeks earlier. They email billing, correct the record, attach the correct insurance card, and ask for resubmission. Then notice the registration screen never required a card image, and propose fixing that gap. Watch for phrases like acknowledge the error, remedy, and corrective action on exam questions. The right answer always owns the mistake, not blame shifting onto the patient, not hiding it, and not a punitive culture that discourages reporting problems in the first place. Question 13. A patient calls the desk and says she sometimes thinks about ending her life and has a plan in mind. The CMAA must respond within scope while keeping the patient safe and supported through the next moments of the call. Which immediate action best fits accepted practice for this scenario? Your options are: A. Stay on, alert clinical staff fast. B. Hang up to free the line. C. Schedule a routine future visit. D. Refer only to a paper handout. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Stay on, alert clinical staff fast. A is correct because staying on the line and alerting clinical staff or calling emergency services if imminent is the recommended action, because a suicidal patient should never be left alone, and the CMAA must escalate inside scope. B is wrong because hanging up abandons a patient in crisis at the moment continued. Contact matters most, contradicting the staying with them principle taught for this kind of disclosure scenario. C is wrong because scheduling a routine future visit treats this as non-urgent when the patient has expressed a plan, missing the immediate safety priority that defines how CMAAs respond to a suicidal disclosure on the phone. D is wrong because referring only to a paper handout fails to provide an immediate human bridge to clinical care and ignores the safety protocol that puts staying with the patient and rapid escalation at the center. When a patient discloses suicidal thoughts with a plan, this becomes a behavioral health emergency. The CMAA's job is immediate human contact and rapid escalation, not scheduling or handouts. The moment of disclosure is fragile. A patient who finds courage to speak is reaching out, and that reach must be met with connection, not with a hang-up, a future appointment, or a pamphlet. The practice's protocol gives a defined script. Stay on the line using calm, supportive language, discreetly alert a triage nurse or behavioral health staff, and document the disclosure, response, and hand off in the chart. Picture a Tuesday call. A patient reveals a plan involving medication at home. The CMR thanks her, asks her to stay on the line, and quietly alerts the triage nurse and behavioral health clinician, who joins within 90 seconds to arrange same-day care. Don't confuse this with routine scheduling for stable patients. A crisis hotline referral as a mere adjunct, the Tarasov duty to warn identifiable victims, or mandatory reporting laws for abuse and neglect. Each is a distinct framework. Question 14. A patient calls and asks for a complete copy of her chart. The CMAA wants to confirm the time frame and any allowed extension under HIPAA's access rule before responding? Which time frame best fits the standard time the practice has to fulfill the request? Your options are A. Within 5 business days only, B. Within 24 hours always, C. Within 30 days, 1 extension allowed, D. Within 1 calendar year always. Which would you go with? Lock it in before the reveal. The correct answer is C. Within 30 days, 1 extension allowed. C is correct because HIPAA gives the patient a right to inspect and obtain a copy of the designated record set, generally within 30 days, with 1 fee-based extension permitted, plus reasonable cost-based fees per applicable limits. A is wrong because 5 business days is shorter than HIPAA's standard time frame and does not match the federal access timeline, which gives covered entities 30 days to fulfill the request with 1 allowed extension. B is wrong because a 24-hour requirement is not HIPAA's access rule. That rule sets a 30-day standard with an allowed extension, with state laws sometimes setting tighter time frames in particular jurisdictions. D is wrong because a 1-year time frame is far longer than HIPAA's access rule allows and would frustrate the patient's right to records, which is built around a 30-day standard with 1 possible extension. The HIPAA privacy rule gives patients the right to inspect and obtain copies of their own designated record set, and understanding the exact timeline is one of the most tested details on the exam. The covered entity must act within 30 calendar days, with 1 permitted 30-day extension if the patient receives written notice of the delay and a new expected date. State laws can tighten this timeline, but 30 days with 1 extension is the federal floor, alongside reasonable cost-based fees. Mechanically, the practice receives a written request. The CMAA verifies the patient's identity, scopes the search to the designated record set, and delivers the records in the requested format, including electronic delivery when the records are kept electronically. Watch for confusable concepts. Subpoena response times follow court rules. Medicare release standards apply to specific functions. State laws may shorten the window for certain records. And the separate right to amend records has its own 60-day standard. When a STEM describes a patient requesting a chart copy, remember the phrases right of access, designated record set, and reasonable cost-based fee, and lock in 30 days with 1 allowed extension as the answer. Question 15. A practice retains adult medical records for several years after the last encounter. The compliance officer reviews retention periods that vary by state law and payer requirements. Which combination of retention parameters best fits accepted general guidance for this kind of policy review across categories of records? Your options are A. Always 1 year for all records, B. Always a decade regardless of state, C. Burn after each visit, D. Adults 7 to 10, minors longer. Don't overthink it. Which one feels right? The correct answer is D. Adults 7 to 10, minors longer. D is correct because common retention guidance is 7 to 10 years for adults from the last encounter, longer for minors, often until age of majority plus the standard period, with state law and payer requirements modifying specifics in many jurisdictions. A is wrong because a 1-year retention period is far shorter than guidance for adult records, which commonly run 7 to 10 years, and would put the practice in conflict with state law and payer requirements. B is wrong because an unconditional decade retention does not capture longer, minor retention periods and ignores variation in state law and payer requirements, so it does not fit the actual range of guidance. C is wrong because burning records after each visit conflicts with retention requirements and the legal record obligations of the practice and is not a defensible retention strategy under any policy framework. Retention policies define how long a practice keeps charts, billing records, and related documents after a patient's last encounter or after a record becomes inactive. Records serve several purposes years after a visit: continuity of care for late returning patients, defense against malpractice claims, audits by payers and regulators, and statistical reporting. Indefinite retention costs storage and complicates privacy, so policies set clear time limits instead. A retention policy lists categories such as adult clinical records, minor clinical records, billing and accounts receivable records, and controlled substance records, each with its own retention period, destruction method, and destruction log. Picture a timeline starting at the last encounter. Adult records run 7 to 10 years. Minor records extend until the age of majority plus that standard period. And at the end, destruction happens by a method that prevents reconstruction. Logged for compliance. On exam day, watch for the phrases retention. 7 to 10 years. Minors, age of majority, and state law variation. The correct answer reflects this layered structure, not a single uniform period or extreme positions like burn after each visit. Question 16. A practice identifies patients before procedures by matching at least 2 specific items, often the full name and date of birth, plus distinguishing similar names. The CMAA recognizes the underlying patient safety goal driving the practice. Which goal best fits the underlying motivation in this kind of identification work? Your options are: A. Identify patients correctly using 2 identifiers. B. Reduce facility lighting at night. C. Lengthen elevator wait times. D. Increase parking sign size. Got a guess? Lock it in. The correct answer is A. Identify patients correctly using 2 identifiers. A is correct because identifying patients correctly using at least 2 identifiers is a Joint Commission national patient safety goal that supports safe care, accurate medication administration, and correct procedures, especially for patients with similar names. B is wrong because reducing facility lighting is not a patient safety goal, since identification work focuses on matching identifiers to the right person rather than environmental controls in the facility itself. C is wrong because lengthening elevator wait times is not a patient safety goal, since identification work focuses on matching identifiers rather than physical timing of building elevators inside the facility. D is wrong because increasing parking sign size is not a patient safety goal, since identification work focuses on patient identifiers at the point of care rather than wayfinding signs outside the facility. Patient identification with at least 2 identifiers is a national patient safety goal set by the Joint Commission. It exists to stop care meant for one patient from reaching another. Relying on room number, bed number, or simply recognizing a face is a single point of failure. Clinics see hundreds of patients weekly, and similar names make one identifier alone unreliable. The patient states their full name and date of birth, rather than confirming information read to them. Staff match both against the chart. Wristband, requisition, or label, so a wrong name is never accidentally confirmed. Don't confuse this with universal protocol, which covers site marking and timeouts, or readback verification for verbal orders, or hand hygiene goals. Lighting and signage are distractors, not the safety principle being tested. Whether at registration, before a procedure, or during a blood draw, matching 2 identifiers is what stands between routine care and a preventable harm. Question 17. A practice runs a daily report showing how many slots filled, how many were vacant, how many same-day fills occurred, and the average lead time for routine visits. The CMAA recognizes the underlying purpose of this regular review. Which purpose best fits this kind of recurring schedule audit? Your options are A. Cancel future visits without notice. B. Lower providers' compensation. C. Identify gaps and improvement opportunities. D. Remove patients from registry. Which one is it? Pause the video if you need more time. The correct answer is C. Identify gaps and improvement opportunities. C is correct because schedule audits identify underutilized slots, overbooked days, same-day fill rates, lead times, and no-show rates, surfacing trends that drive improvement and template adjustments by the operations leader and the clinical team. A is wrong because schedule audits do not cancel future visits. They review aggregate patterns to inform improvements rather than cancelling appointments that have already been booked with patients on the calendar today. B is wrong because compensation policy is set separately and is not the purpose of a daily schedule audit, which focuses on capacity, demand, and patterns rather than how providers are paid by the organization. D is wrong because removing patients from a registry is a separate clinical or administrative action and is not the purpose of routine schedule audits, which focus on appointment patterns rather than patient registry membership. Schedule audits review aggregated calendar performance data, not individual patients or provider pay. Their purpose is to spot gaps and improvement opportunities in capacity, demand, and template design. Mechanically, audits pull metrics like slot fill rate, vacant slot counts, same-day fill rate, lead time, and no-show rate from the scheduling system into a dashboard or report. Rising lead times signal a capacity shortfall, while no-show patterns flag unreliable time slots or patient subgroups. Picture a clinic's 7:30 morning report, 140 visits scheduled, 6 vacant slots. All 4 held same-day slots filled, and routine lead time climbing from 9 to 14 days. Recognizing that demand has outpaced capacity, the team adds a half day of provider time and raises held slots from 4 to 6. Don't confuse this with provider productivity reports, which track revenue and volume, or patient satisfaction surveys and HEDIS quality scores, which measure experience and clinical care. Capacity planning models are related but forward-looking, projecting future need rather than auditing current performance. The exam writer's trap is framing audits as punitive, cutting patients or pay. The correct framing is always operational improvement, identify gaps, adjust templates, and keep the schedule matched to real demand. Question 18. A workers' compensation visit requires a separate billing path from regular health insurance, including the claim number and adjuster contact. The CMAA recognizes the underlying billing path. Which combination best fits accepted workers' compensation billing in this kind of work injury scenario at the practice today? Your options are A. Marketing slogan, logo, mascot. B. Claim number, adjuster, itemized bill. C. Birthday, anniversary, favorite color. D. Pet name, vacation plans, songs. Take a second. Which answer would you pick? The correct answer is B. Claim number, adjuster, itemized bill. B is correct because workers' compensation billing requires the claim number from the employer or carrier, an adjuster contact, often itemized bills, and may involve independent medical examination reports per the state's workers' compensation rules. A is wrong because marketing items are unrelated to workers' compensation billing, which focuses on the claim number, adjuster contact, and required documentation rather than promotional content for the practice or the carrier. C is wrong because birthdays and anniversaries are unrelated to workers' compensation billing, which focuses on the claim number, adjuster contact, and required documentation rather than personal lifestyle facts about the patient or staff. D is wrong because pet names and vacation plans are unrelated to workers' compensation billing, which focuses on the claim number, adjuster contact, and require documentation rather than personal lifestyle facts at the practice. When an employee gets hurt on the job, billing follows a completely different path than regular health insurance. Let's look at why this system exists and exactly what data makes it work. Workers' compensation exists because of a no-fault system. Employees get medical care and wage replacement without having to prove their employer was negligent, and in exchange, employers receive limited liability protection. Mechanically, the front desk captures the data of injury, employer name, claim number, and adjuster name and phone. The claim is then submitted with itemized charges, and the encounter must document how the visit relates to the original injury. Picture a patient who slipped at a warehouse, handing over an authorization slip with the employer, claim number, and adjuster contact. The CMAA enters the workers' comp carrier as the payer, links the claim number, and documents the injury connection. Watch for confusable claim types on exam day. Auto accident claims go through auto insurers. Personal injury claims may pen behind settlement. Standard health claims go to the patient's regular plan. And disability insurance covers wage replacement through a separate carrier entirely. Question 19. A small practice has migrated from paper charts to a cloud-hosted system accessed through a web browser, with the database maintained in the vendor's data center. Which advantage of this format does the migration most directly provide to the practice staff? Your options are: A. Single location access only. B. Higher upfront server costs. C. More storage room for charts. D. Anywhere access with credentials. Before I reveal it, which one do you think is right? The correct answer is D. Anywhere access with credentials. D is correct because cloud-hosted electronic health records allow authorized staff to access patient information from anywhere with valid credentials and a stable connection, which is one of the major advantages over paper or locally hosted systems. A is wrong because single location access is a defining limitation of paper records or strictly local servers. Cloud-hosted systems were designed to overcome that constraint by allowing access from any approved device with credentials. B is wrong because cloud-hosted systems are typically subscription-based and shift large server purchase costs onto the vendor, so the migration generally lowers upfront hardware spending rather than raising it for the practice. C is wrong because cloud-hosted systems do not require the practice to maintain physical chart storage rooms, since records reside electronically in the vendor's secure data center rather than in on-site filing cabinets. Cloud-hosted electronic health records store the database in the vendor's data center, delivering access through a browser instead of an on-site server. Traditional locally hosted systems demand heavy upfront investment in servers, networking, and IT staff, which smaller practices often cannot afford. Cloud hosting shifts that burden to the vendor in exchange for a subscription, though the practice now depends on internet connectivity and the vendor's security. Mechanically, the vendor secures the database with redundant servers, encryption, and backups, while staff log in through a browser using credentials and often a second factor. Updates roll out automatically from the vendor, while the practice manages training and access policy on its end. Picture a two-location practice that just moved from paper to the cloud. The lead provider finishes notes from home, and the billing manager works from a satellite office the next day. When a flood damages one site's network closet, staff simply move to the other location and keep working, since the database lives in the vendor's data center, not in a closet. Watch for phrases like cloud-hosted, browser, vendor data center, and anywhere access. The most distinctive benefit of cloud systems is flexible access from any approved device, not just lower costs or vendor maintenance. Question 20. A radiology report describes a finding on the patient's right lower quadrant that contains the appendix. The CMAA must explain the location to a curious patient using the standard 4-quadrant abdominal scheme. Which structure is most appropriately associated with this region in the 4-quadrant approach? Your options are A. Appendix and cecum, B. Stomach and spleen, C. Liver and gallbladder, D. Sigmoid colon and ovary. What's your answer? Commit to one before I continue. The correct answer is A. Appendix and cecum. A is correct because the right lower quadrant contains the appendix and cecum, plus the right ovary and fallopian tube in patients with female anatomy. So RLQ pain is often considered for appendicitis or right-sided pelvic causes. B is wrong because the stomach and spleen are located in the left upper quadrant, not the right lower quadrant, so they would not be the structures associated with the appendix region described in the report. C is wrong because the liver and gallbladder are located in the right upper quadrant, so right upper quadrant pain often suggests biliary pathology, while the right lower quadrant houses the appendix and cecum instead. D is wrong because the sigmoid colon and left ovary sit in the left lower quadrant, so left lower quadrant pain is more typical for diverticulitis or left-sided pelvic causes than the right lower region. Clinicians divide the abdomen into 4 quadrants using the umbilicus as the crossing point, giving everyone a shared shorthand for describing where something is found. The right upper quadrant holds the liver, gallbladder, and right kidney. The left upper quadrant holds the stomach, spleen, and left kidney. The right lower quadrant holds the appendix and cecum, and the left lower quadrant holds the sigmoid and descending colon. The scheme exists because saying right lower quadrant pain conveys a precise location instantly, without needing detailed coordinates, and it's used across exams, documentation, radiology reports, and patient communication. The single highest yield fact to memorize is that the appendix lives in the right lower quadrant, since appendicitis appears so often in clinical scenarios, and students who lock in that structure to quadrant map score reliably on these questions. When you hear right lower quadrant, think appendix and cecum first, and you'll rarely go wrong. Question 21. An adjustment is recorded after a small balance falls under the practice's threshold of $10. The CMAA recognizes the category in this kind of routine cleanup work. Which category best fits this kind of low-value cleanup adjustment in the practice's accounting structure during a reconciliation review today? Your options are A. Charity care write-off, B. Bad debt write-off, C. Small balance write-off, D. Statute of limitations write-off. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Small balance write-off. C is correct because small balance write-offs remove balances that fall under a defined dollar threshold, often around $10, since pursuing them costs more in staff time and statements than the balance itself would recover. A is wrong because charity care write-offs apply when the patient qualifies through a means-tested financial assistance application, which is a different category than a low-value cleanup adjustment under a dollar threshold. B is wrong because bad debt write-offs apply when collection efforts have failed rather than to a low-value cleanup adjustment under a dollar threshold, which is a different category in the practice's accounting structure. D is wrong because statute of limitations write-offs apply when the time limit for filing or collection has passed, which is a different category from a low-value cleanup adjustment under a dollar threshold today. Small balance write-offs clear patient balances that fall below a set dollar threshold, often around $10, because chasing them costs more than they're worth. Billing cycles naturally leave small residual balances from rounding, copay adjustments, and secondary insurance changes. A balance of $3.50 is real, but sending a statement or making a follow-up call costs more than the balance itself. So the practice simply zeroes it out. Mechanically, the billing policy sets the threshold and approval level. The system runs a periodic batch to flag eligible accounts. A supervisor approves, and the adjustment posts under a small balance write-off code with totals tracked monthly for leadership review. The exam nuance is matching category to scenario. Bad debt applies after failed collection on a meaningful balance. Contractual adjustments are the routine gap between billed and allowed amounts. And charity care requires a means-tested application. Small balance write-offs apply purely based on the threshold, regardless of ability to pay. Watch for stems where the balance is adjusted simply because it fell under a defined dollar threshold, not because of failed collections or financial hardship. That signal points straight to small balance write-off. Question 22. A CMAA documents a phone encounter in the EHR after speaking with a patient about a medication refill request. The supervisor reviews the note for completeness using documentation standards. Which set of details best fits the recommended content of a documented telephone encounter for this kind of refill conversation? Your options are A. Patient mood and gossip from neighbor. B. Personal opinion of the requesting patient. C. Lengthy speculation about the diagnosis. D. Caller, verification, content, action, signature. Which would you go with? Lock it in before the reveal. The correct answer is D. Caller, verification, content, action, signature. D is correct because a complete telephone encounter records the caller, identity verification, content of the conversation, action taken, follow-up plan, and the staff signature, which makes the note useful for both the clinician and the patient. A is wrong because patient mood from a neighbor and gossip do not belong in the legal record. Documentation reflects verified, factual content from the encounter, rather than third-party speculation. B is wrong because personal opinion of the requesting patient injects subjective judgment into a legal record and conflicts with the objective, verbatim style recommended for documenting communications in the chart at any visit. C is wrong because lengthy diagnostic speculation exceeds the CMAA's scope, can mislead later readers of the chart, and does not satisfy the recommended structure of a telephone encounter note in any clinical record system. Telephone encounter notes document patient calls like refill requests, results discussions, and symptom reports. Because they become part of the legal medical record, they follow a disciplined structure rather than informal jotting. A phone call about a refill or a symptom carries the same clinical weight as an office visit, so it needs the same reliability. Consistent structure keeps details from getting lost, lowers clinical risk, and protects the staff member by showing exactly what was said and done. Mechanically, the note opens with caller identification and verified identifiers, then captures the content of the call, the action taken, the follow-up plan, and closes with a signature, date, and time. Each section exists so the next clinician sees the full picture. The exam trap is choosing answers that slip in subjective opinions, gossip, or diagnostic speculation. A telephone encounter note records only what was said and done, never what the staff member thought about the patient, since that exceeds the CMAA's scope and could mislead a later reader. Telephone encounter notes share the same legal weight as any chart entry, but use a focused structure built for phone work, caller identification, content, action, follow-up, and signature. Question 23. A patient who has been clearly informed of risks, benefits, and alternative signs a written form before a planned surgery. The CMAA recognizes the type of consent involved. Which type of consent best fits this scenario? Distinct from emergency or routine implied consent at the practice today? Your options are A. Implied consent only, B. Informed written consent, C. Waived consent in research, D. Verbal consent without explanation. Don't overthink it. Which one feels right? The correct answer is B. Informed written consent. B is correct because informed consent requires that the patient understands the nature, purpose, risks, alternatives, and benefits of a proposed procedure and signs voluntarily, with the provider responsible for the actual disclosure and discussion process. A is wrong because implied consent is inferred from action or circumstance, such as rolling up a sleeve for blood draw, and does not match a planned surgery with formal disclosure and signature on file. C is wrong because waived consent is rare and applies in research with IRB approval rather than to routine surgical procedures, so it does not match the consent type described in this scenario at the practice. D is wrong because verbal consent without explanation lacks the disclosure of risks, alternatives, and benefits required for informed consent, so it does not satisfy the standard for a planned surgical procedure here. Informed consent is the process by which a patient learns the nature, purpose, benefits, risks, and alternatives of a procedure, then voluntarily agrees in writing. The provider performing the procedure is responsible for that disclosure and discussion. The provider must cover the nature of the intervention, its purpose, the expected benefits, the material risks, and the alternatives, including doing nothing. The signed form only documents that this discussion happened. This principle exists because patients have the right to decide what happens to their own bodies. A procedure done without proper consent is legally battery, no matter how beneficial it turns out to be. Implied consent is inferred from action, like rolling up a sleeve for a blood draw. Verbal consent without explanation lacks true disclosure. Waived consent applies only in approved research settings. And informed written consent is required for planned procedures with full disclosure and signature. Picture a surgeon sitting with a patient before an outpatient procedure, walking through the steps, recovery, and risks like bleeding, infection, and damage to nearby structures, plus the alternative of non-operative management. The patient signs, and on surgery day, the team verifies that valid informed consent is on file. Question 4. A non-profit hospital writes off a balance for a low-income patient after a means-tested application is approved. The CMAA recognizes the category of write-off involved. Which category best fits this write-off in the standard revenue cycle classification? Your options are A. Charity care write-off, B. Bad debt write-off, C. Contractual adjustment, D. Statute write-off. Got a guess? Lock it in. The correct answer is A. Charity care write-off. I is correct because charity care write-offs reduce charges based on inability to pay through a means-tested financial assistance policy, with non-profit hospitals required by the Affordable Care Act to maintain a written financial assistance policy. B is wrong because bad debt write-offs apply when collection efforts have failed rather than when the patient qualifies for charity care through a means-tested application, so the categories are reported separately. C is wrong because contractual adjustments are the routine difference between billed charges and the contracted allowed amount for in-network claims, which is a different category from charity care entirely at the hospital. D is wrong because statute write-offs apply when the time limit for filing or collection has passed, which is a different category from charity care based on a means-tested financial assistance application. Charity care write-offs reduce or eliminate charges for patients who qualify for a practice's financial assistance policy through a means-tested application. Non-profit hospitals are required to maintain and publish this policy, and this category is tracked separately because it reflects mission-driven generosity, not a failed collection effort. The patient submits an application with proof of income and household size, often measured against the federal poverty level. Eligibility staff review the documentation and apply published thresholds, then post the approved write-off with a charity care code so leadership can track how much care is delivered this way. Picture a patient with a $2,400 balance after insurance, submitting proof that household income sits at 150% of the federal poverty level. The hospital's policy grants a full write-off at that level, the counselor approves it, and the balance drops to zero while the dollars roll into required community benefit reporting. The exam trap is confusing charity care with bad debt since both can leave a zero balance, but charity care follows a documented application and an approval decision, while bad debt follows failed collection on a balance worth pursuing. Small balance write-offs ignore ability to pay entirely, and statute write-offs simply reflect an expired filing deadline. When a STEM describes a successful means-tested application rather than exhausted collection efforts, the answer is charity care. Question 25. A staff member is reviewing a chart and hesitates over what counts as PHR. She lists name, full date of birth, address, phone, and email. The CMAA confirms which elements count. Which response best fits the HIPAA list of identifiers for this kind of review of items in the chart? Your options are A. Only the name counts. B. Only address and phone count. C. All of the listed items count. D. Only the email counts as PHR. Which one is it? Pause the video if you need more time. The correct answer is C. All of the listed items count. C is correct because names, addresses smaller than a state, dates other than year, phone numbers, fax numbers, and email addresses all appear on the 18 identifiers, alongside SSNs, MRNs, account numbers, biometrics, photos, and unique codes. A is wrong because limiting PHR to the name leaves out addresses, dates, contact details, and many other identifiers that all appear on HIPAA's 18 identifier list and must be handled with the same protections. B is wrong because limiting PHR to address and phone leaves out name, dates, email, and many other identifiers, which is far narrower than HIPAA's actual 18 identifier framework for protected information. D is wrong because limiting PHR to email alone leaves out names, dates, addresses, phone numbers, and many other identifiers, which is far narrower than HIPAA's actual 18 identifier list for protected information. HIPAA defines 18 identifiers that, when linked to health information, turn it into protected health information subject to strict use and disclosure rules. The list is broad, covering obvious items like name, date of birth, address, phone, and email, plus less obvious ones like medical record numbers, device identifiers, and biometric data. On exam day, when a STEM lists common patient items, remember, all of them count as protected. Picture a CMAA reviewing a chart with a patient's name, birth date, address, phone number, and email. Every one of these appears on the 18 identifier list, so combined with health information, the entry becomes protected health information requiring access controls and minimum necessary handling. Removing all identifiers creates de-identified data that's free of HIPAA restrictions through expert determination or the safe harbor method of stripping all 18 identifiers. Limited data sets keep some elements like dates and zip codes, but require a data use agreement. while fully aggregated data falls outside protected health information entirely. When in doubt, the safe harbor list is comprehensive. Names, dates, addresses, and contact details all count as protected health information. Question 26. A CMAA is registering a patient who is hard of hearing. The patient prefers written communication and the visit involves financial counseling. Which set of accommodations best matches a recommended practice for serving a hearing-impaired patient at the front desk during intake conversations? Your options are A. Yell from across the lobby. B. Use whispered voice for privacy. C. Insist on phone-based discussion. D. Face patient, offer ASL or written. Take a second. Which answer would you pick? The correct answer is D. Face patient, offer ASL or written. D is correct because facing the patient, speaking clearly without exaggeration, reducing background noise, and offering an ASL interpreter or written communication respects effective communication requirements and supports an accurate financial conversation that the patient can fully follow. A is wrong because yelling distorts speech and breaches privacy through volume. It does not help a hearing-impaired patient who would benefit far more from clear face-to-face cues and visuals. B is wrong because whispering masks speech rather than clarifying it, which is the opposite of what supports lip reading or assistive listening devices, even when the goal is to keep financial details private and respectful. C is wrong because insisting on phone-based discussion strips away the visual cues that often help hearing-impaired patients, making understanding harder rather than easier in a sensitive financial conversation that affects care plans. Communication is the foundation of every patient interaction, from consent to financial counseling. Let's look at why accommodations for hearing-impaired patients matter and how to get them right. Federal law requires covered entities to provide effective communication for patients with disabilities. That means facing the patient, cutting background noise, arranging a sign language interpreter on request, and offering written materials, always guided by the patient's own preference. Exam writers love to test tempting wrong answers. Whispering masks speech and blocks lip reading. Phone-based discussion strips away visual cues, and yelling doesn't help either. All three feel considerate but actually create barriers instead of removing them. Picture a CMAA registering a hearing-impaired patient who prefers written communication. She seats him in a quiet area, faces him at eye level, and writes key figures like out-of-pocket costs on a shared notepad, then confirms understanding by having him summarize it back. The correct answer always combines facing the patient with honoring their expressed preference, whether that's an interpreter or written notes. Effective communication is both a legal obligation and a basic form of respect. Question 27. A new patient asks how an electronic medical record differs from an electronic health record. The CMAA provides a brief plain language explanation that aligns with how the two terms are used in modern practice. Which statement best captures the distinction between them? Your options are A. EMR is single practice, EHR shares. B. EMR holds only billing information. C. EHR is paper, EMR is digital. D. Both are the same product. Before I reveal it, which one do you think is right? The correct answer is A. EMR is single practice, EHR shares. A is correct because an electronic medical record is generally a single practice's digital chart, while an electronic health record is designed to be shared across organizations and to reflect the patient's complete longitudinal health history. B is wrong because an electronic medical record is the digital clinical chart for a practice and contains far more than billing information, including problem lists, medications, allergies, and encounter notes for the patient. C is wrong because both EMR and EHR refer to digital records. Paper records are a separate, older format used in some small practices and as backup during downtime, not a defining trait of either acronym. D is wrong because the two terms are commonly distinguished on the exam and in policy guidance, where EMR refers to a single practice and EHR refers to a record built for sharing across organizations. Electronic medical record and electronic health record sound interchangeable, but exam writers care deeply about one key difference: whether the record stays inside a single practice or travels across organizations. An electronic medical record is the digital chart generated by one practice or organization. An electronic health record is built to be shared across organizations, pulling together a patient's complete longitudinal history from primary care, specialists, hospitals, and pharmacies. Mechanically, each practice's electronic medical record holds problem lists, medications, allergies, vitals, notes, labs, imaging, and immunizations. An electronic health record adds feeds from other organizations through standards like CCDs, direct messaging, and FHIR, letting patients view it all through a portal. Watch for confusable terms. A personal health record is patient-controlled. A health information exchange is the infrastructure connecting EMRs, and interoperability standards define how systems talk to each other. On exam day, look for phrases like single practice versus share across organizations and longitudinal record. Maxa Yezen TDs. That shareability distinction is exactly what separates an EMR from an EHR. Question 28. A new patient asks the CMA to summarize key rights the practice extends at registration, including informed consent, privacy, access to records, and the right to file a complaint without retaliation. Which document or framework best matches the source the CMAA is summarizing for this conversation? Your options are A. OSHA Bloodborne Standard, B. Joint Commission Universal Protocol, C. Patient's Bill of Rights, D. ICD-10 CM Coding Guidelines. What's your answer? Commit to one before I continue. The correct answer is C. Patient's Bill of Rights. C is correct because the Patient's Bill of Rights articulates rights such as high-quality care, information, informed consent, refusal, privacy, confidentiality, access to records, and the right to file complaints without retaliation against the patient. A is wrong because the OSHA bloodborne pathogens standard protects workers from exposure to infectious materials, which is a workplace safety regulation rather than a statement of patient rights at registration. B is wrong because the Joint Commission Universal Protocol covers pre-procedure verification, site marking, and timeout for invasive procedures rather than the patient rights framework being summarized for the new patient today. D is wrong because the ICD-10 CM Coding Guidelines describe how to assign diagnosis codes, which is a coding reference rather than a statement of patient rights extended at registration to inform new patients. Healthcare puts patients in a vulnerable spot, sick, uncertain, and dependent on professionals whose decisions can feel impenetrable. The Patient's Bill of Rights exists to balance that power gap by giving patients a clear baseline the system must honor. The framework spells out specific rights: high-quality care, information about one's condition and treatment, informed consent, the right to refuse care, privacy and confidentiality, access to one's own records, and the right to file complaints without retaliation. In practice, the CMAA weaves this into registration. The rights summary sits in the packet, on waiting room signage, and in patient handouts. The CMAA may briefly walk through informed consent, privacy, records access, and the complaint process, then has the patient sign an acknowledgement that goes straight into the chart. Exam writers love to swap in lookalike documents. The OSHA Bloodborne Pathogens Standard protects workers from infectious exposure. Universal Protocol governs pre-procedure surgical safety. ICD-10 CM guidelines govern diagnosis coding. And HIPAA's Notice of Privacy Practices covers protected health information, related, but each a separate document with its own purpose. Whenever a STEM mentions informed consent, privacy, records access, filing a complaint, or rights explained at registration, think Patient's Bill of Rights. Question 29. A handwritten chart note reads 10.0 milligrams for a medication dose, including a trailing zero after the decimal point. The CMAA recognizes the trailing zero as a flagged dose designation. Which safer convention should be applied when documenting whole number doses going forward? Your options are: A. Use a leading zero only. B. Drop the trailing zero entirely. C. Write 10.0 in words. D. Add an explanatory parenthesis. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Drop the trailing zero entirely. B is correct because whole number doses should be written without a trailing zero. So the safer convention is 10 milligrams instead of 10.0 milligrams, since the decimal can be missed and the dose must read as 100. A is wrong because leading zeros are required for fractional doses such as 0.5 milligrams to prevent the decimal from being missed, but that rule does not address whole numbers needing a trailing zero removed. C is wrong because writing 10.0 in words preserves the trailing zero and the same risk, since transcribing into a numeric entry can reintroduce the decimal misread that the rule aims to prevent. D is wrong because an explanatory parenthesis adds clutter without addressing the underlying issue, since the safety standard is to omit the trailing zero entirely whenever a whole number is being recorded for the dose. Why does a tiny zero after a decimal point matter so much in medication documentation? Because it can silently turn a safe dose into a dangerous overdose. Writing 10.0 milligrams looks precise, but if that decimal point is missed or smudged, a reader sees 100 milligrams instead of 10. That's a tenfold overdose caused by a single stray zero. The trailing zero rule and the leading zero rule are easy to confuse but solve different problems. Trailing zeros get dropped from whole number doses, while leading zeros get added to fractional doses, so a bare decimal point is never missed. Both rules exist to eliminate common misread patterns. Picture a CMAA reviewing a chart note reading 10.0 milligrams. She flags it to the supervisor and prescriber, who confirms the intended dose was 10 milligrams and corrects the record using the safer convention. Whole numbers stand alone and fractions always get a leading zero. Mastering this small distinction prevents one of the most common and dangerous documentation errors in medicine. Question 30. A supervisor coaches a CMAA to avoid endearments such as honey or sweetie when addressing patients, even though the team uses them informally outside work. Which professional principal best explains why the supervisor is making this coaching point at the front desk on a busy morning? Your options are: A. Endearments save patients time. B. Endearments are required for kindness. C. Endearments prevent any HIPAA breach. D. Endearments can feel patronizing. Which would you go with? Lock it in before the reveal. The correct answer is D. Endearments can feel patronizing. D is correct because endearments such as honey or sweetie can feel patronizing, especially with older adults, and undermine respect. So the supervisor's guidance is to use formal address until invited otherwise to use a different name. A is wrong because endearments do not save time and can cost trust, since recovery from a patronizing exchange takes longer than simply using a respectful name and title from the start of the interaction. B is wrong because kindness does not require endearments and is conveyed through tone, attentiveness, and respectful language, so the practice is not lost when the team avoids honey and similar terms with patients. C is wrong because HIPAA breaches involve unauthorized disclosure of protected information rather than informal language, so endearments do not by themselves prevent a privacy event in the registration encounter at the desk. Why does calling a patient honey or sweetie cross a line that feels harmless to staff but can feel disrespectful to patients? The answer lies in a mismatch between intent and perception. Healthcare professionals interact with patients across age, culture, and background. An older adult called honey may feel infantilized. A patient with significant accomplishments may feel her status is unrecognized. And a patient from a culture emphasizing formal address may feel disrespected. The asymmetry between staff intent and patient perception is the core problem. Picture a busy front desk on a Monday morning. A CMAA greets an 80-year-old patient with "Hi, sweetie," and the supervisor pulls her aside afterward to coach the use of Mrs. and the patient's last name instead, framing it as a respect issue rather than a personality flaw. Don't confuse this with related ideas. Cultural competence is the broader skill of adapting to communication preferences. Trauma-informed care avoids re-traumatizing language. HIPAA protects confidential information. And person-first language addresses how conditions are described, not how patients are addressed by name. Kindness comes through tone and attentiveness, not endearments. The cipher default is Mr., Mrs., Doctor, or whatever title the patient prefers, until they invite something less formal. Question 31. A new patient writes the name Alex on the intake form, requests they them pronouns, and asks staff to use these consistently throughout the visit. Which response by the CMAA best matches inclusive practice and supports both registration accuracy and the patient's care experience overall? Your options are: A. Document and use chosen name and pronouns. B. Override with legal name only. C. Use pronouns only with this provider. D. Ignore pronoun request entirely. Don't overthink it. Which one feels right? The correct answer is A. Document and use chosen name and pronouns. A is correct because documenting the chosen name and pronouns in the appropriate fields and using them consistently from check-in onward respects the patient, supports accurate identification, and improves engagement and outcomes documented in the literature. B is wrong because overriding with legal name only ignores the chosen name field that modern records support, increases the chance of misgendering, and undermines the trust that supports honest disclosure during care visits. C is wrong because using pronouns only with one provider creates inconsistent care and leaves room for harmful misgendering during check-in, rooming, and follow-up, which is exactly what the inclusive practice aims to avoid. D is wrong because ignoring a pronoun request is disrespectful, conflicts with documented inclusive practice, and is associated with delayed or avoided care among LGBTQ+ patients who have experienced past mistreatment in clinics. Inclusive practice for transgender, non-binary, and gender-diverse patients starts with one core habit: using the patient's chosen name and pronouns consistently, from check-in to check-out, in every interaction and every record. This matters because LGBTQ+ patients have often faced mistreatment in healthcare, causing many to delay or avoid care. A patient who is repeatedly misgendered loses trust, discloses less, and returns less often. So the chosen name and pronoun fields are workflow tools for honoring identity, not paperwork add-ons. Registration captures legal name, chosen name, pronouns, and gender identity in separate fields. Visit summaries, banners, and clinical notes then pull from the chosen name and pronoun fields at every step. Check-in, rooming, the clinical encounter, and check-out, while legal name stays reserved for billing or legal purposes. Exam questions test consistency. Partial use, like honoring the request with only one provider, still causes harm. It also helps to keep terms distinct. Gender identity is how a patient identifies. Sexual orientation is who they're attracted to. Sex assigned at birth serves clinical purposes like screening, and legal name belongs on government documents only. When a slip happens, a brief correction is enough. No lengthy apology needed, just the correct name going forward. The correct answer on exam day is always the one that applies chosen name and pronouns consistently across the entire visit. Question 32. A claim form lists a diagnosis code beginning with a letter and a number with up to 7 characters. Which code set best fits this format used for diagnoses in modern billing across all healthcare settings under current standards? Your options are A. CPT procedure code set, B. HCPCS level 2 code set, C. ICD-10 CM diagnosis code set, D. NDC 11-digit drug code. Got a guess? Lock it in. The correct answer is C. ICD-10 CM diagnosis code set. C is correct because ICD-10 CM codes diagnoses, signs, symptoms, and reasons for visits with 3 to 7 alphanumeric characters, including a letter first, used across all healthcare settings to support medical necessity and billing. A is wrong because CPT codes professional services and procedures with a 5-digit numeric format for Category 1 codes, which is a different code set than the diagnosis-focused ICD-10 CM described in this scenario. B is wrong because HCPCS Level 2 codes products, supplies, and services not in CPT with a 1-letter plus 4-digit format, which is a different code set than the diagnosis-focused ICD-10 CM described. D is wrong because the National Drug Code is an 11-digit code identifying specific drugs by labeler, product, and package size, a different code set than the ICD-10 CM diagnoses described. ICD-10 CM is the diagnosis code set used across all US healthcare settings since October 2015. It replaced ICD-9 CM and aligned the United States with World Health Organization disease classification standards. This code set exists because billing, public health reporting, research, and quality measurement all depend on standardized diagnosis data. ICD-10 CM expanded from roughly 14,000 codes under ICD-9 CM to over 70,000, enabling far greater clinical specificity. Mechanically, every ICD-10 CM code starts with a letter, followed by digits, building out to 7 characters total. Those extra characters add specificity for laterality, episode of care, and other clinical detail. The key exam nuance is format plus purpose. CPT codes professional services with 5 numeric digits. HCPCS Level 2 codes supplies with a letter plus 4 digits. And the National Drug Code identifies drugs with 11 digits. Only ICD-10 CM starts with a letter and describes a diagnosis, not a procedure or product. Whenever you see a code beginning with a letter followed by digits, up to 7 characters total, describing a diagnosis, that's your signal for ICD-10 CM. Question 33. A receiver of a verbal order for warfarin reads back the medication name, dossier, and frequency to the prescriber and waits for confirmation before entering it. The CMAA recognizes this as a safety practice required by accreditation. Which technique is the receiver demonstrating in this exchange? Your options are A. Concurrent dual entry, B. Open-ended interviewing, C. Chronological documentation, D. Readback verification. Which one is it? Pause the video if you need more time. The correct answer is D. Readback verification. D is correct because readback verification is required by Joint Commission for verbal and telephone orders, with the receiver repeating the order, including drug name spelling and dose units, and the prescriber confirming the message. A is wrong because concurrent dual entry is not a recognized safety practice and would not capture the verbal exchange between prescriber and receiver that the readback standard explicitly requires for verbal orders. B is wrong because open-ended interviewing is a questioning technique that elicits narrative responses from a patient, not a method for confirming a verbal medication order and reading it back to the prescriber. C is wrong because chronological documentation describes the order in which entries appear in a chart, but it does not capture the back-and-forth verification step that readback standards demand for verbal medication orders. Readback verification is the Joint Commission's safety standard for verbal and telephone orders, designed to catch errors before they ever reach the patient. Spoken words can be lost or twisted, especially with sound-alike drug names, similar doses, or background noise. A verbal order for hydroxyzine could easily be misheard as hydralazine, two drugs with very different effects. Mechanically, the receiver writes down the order, then reads back every element drug name with spelling, dose, units, route, and frequency. The prescriber confirms. The receiver enters it with a verbal order indicator, and the prescriber co-signs later. Exam writers like to test confusable concepts. Closed-loop communication is the broader category readback belongs to. Timeout is a separate procedural check. To-identifier verification confirms patient identity, and barcode administration is a bedside technology check, not a verbal readback. Watch for stems where a receiver repeats an order back to the prescriber and waits for confirmation. That repeat and confirm pattern is the textbook definition of readback verification. Question 34. A patient discloses imminent intent to harm a named individual. The clinical team reviews the policy on warning duties. Which doctrine best fits the framework that may require warning identifiable victims and notifying law enforcement in some states under specific conditions? Your options are A. Doctrine of res judicata, B. Tarasov Doctrine, C. Common Rule Research Consent, D. Locality Rule for Malpractice. Take a second. Which answer would you pick? The correct answer is B. Tarasov Doctrine. B is correct because the Tarasov Doctrine, varying by state, may require warning identifiable victims and notifying law enforcement when a patient expresses an imminent threat to a specific person under listed clinical conditions. A is wrong because res judicata is a procedural doctrine preventing relitigation of decided matters in court, which is unrelated to clinical duties to warn under threat of harm scenarios in patient care settings. C is wrong because the Common Rule for Research Consent governs federally funded human subjects research, which has no role in the threat of harm warning framework that applies in clinical mental health crises. D is wrong because the Locality Rule for Malpractice concerns standards of care and geographic comparison, which is unrelated to the warning duty framework that applies when a patient expresses imminent intent to harm someone. The Tarasov Doctrine comes from a 1976 California Supreme Court case, and it defines when mental health professionals must warn an identifiable victim or notify law enforcement about a patient's imminent, specific threat. The original case involved a patient who told his therapist he intended to kill a specific young woman. The therapist took limited action and she was later killed. The court ruled that this created a duty to warn or protect. Mechanically, a practice policy defines when the duty triggers. Who is authorized to decide, and what steps to take? The clinical team, not the front desk, makes that call, and the CMAA's job is simply to route the disclosure to clinical leadership without delay. Exam writers like distractors that sound legalistic but mean something else. Res judicata is about litigation finality. The locality rule concerns malpractice standards of care. The common rule governs research consent, and mandatory reporting covers suspected abuse or neglect, not outward threats. Watch for the phrases duty to warn, identifiable victim, and imminent threat directed at a specific person. That combination signals Tarasov, distinct from suicidal disclosure protocols and general HIPAA safety exceptions. Question 35. A patient calls and the CMAA answers the phone within 3 rings. The CMAA wants the greeting to identify the practice, the staff member, and an offer to help while remaining professional. Which sample greeting best matches the recommended phone etiquette pattern at the start of a call? Your options are A. Practice name, staff name, offer help. B. Hello, this is the doctor speaking. C. Yeah, what do you want today? D. Sorry, we are too busy now. Before I reveal it, which one do you think is right? The correct answer is A. Practice name, staff name, offer help. A is correct because the recommended pattern names the practice, the staff member, and an offer of assistance, such as Riverside Internal Medicine, this is Maria, how may I help you, which sets a professional tone for the call. B is wrong because claiming to be the doctor on the phone misrepresents the role and risks, unauthorized disclosure or advice. CMAAs identify themselves accurately and stay within scope while taking calls at the desk. C is wrong because informal openings such as yeah, what do you want today come across as dismissive and unprofessional, which is the opposite of the warm and clear opening the etiquette pattern is meant to establish. D is wrong because leading with apologies for being too busy to take the call signals avoidance rather than service and frames the patient as an inconvenience, which the recommended greeting pattern is designed to prevent. Telephone etiquette sets the professional tone of a practice from the very first ring. Let's break down exactly what the recommended greeting pattern includes and why it matters. The recommended greeting has 3 required components: the practice name, the staff member's name, and an offer of help. All 3 must be delivered within the first 3 rings. Like Riverside Internal Medicine, this is Maria. How may I help you? The phone is often a patient's very first contact with the practice. A vague or dismissive greeting signals the caller is a burden, while a warm, clear one sets a positive tone even for a difficult call. Each part of the greeting serves a purpose. The practice name orients the caller, the staff name personalizes the call, and the offer of help transitions into the reason for calling. Exam questions often test whether you catch incomplete greetings, misrepresentation of role, or unprofessional openings such as an informal yeah or an apologetic excuse. The full 3-part pattern is the only correct standard. Question 36. A patient signs an acknowledgement that the practice has provided a notice describing how protected information may be used and disclosed. The CMA recognizes the form. Which document best fits this acknowledgement in the registration packet? Distinct from billing-related forms used at the same intake encounter? Your options are A. Assignment of benefits document, B. Advanced beneficiary notice form, C. OSHA exposure control plan, D. Notice of privacy practices acknowledgement. What's your answer? Commit to one before I continue. The correct answer is D. Notice of privacy practices acknowledgement. D is correct because the Notice of Privacy Practices Acknowledgement confirms the patient received the privacy notice at first encounter. with HIPAA requiring a good faith effort to obtain a written acknowledgement from the patient at registration. A is wrong because the assignment of benefits authorizes the insurer to pay the practice directly, which is a billing form distinct from the privacy notice acknowledgement that the patient is signing in this scenario today. B is wrong because the advance beneficiary notice informs Medicare patients that a service may not be covered, which is a different document tied to medical necessity decisions rather than the privacy notice acknowledgement. C is wrong because the OSHA Exposure Control Plan describes workplace bloodborne pathogen protections, which is unrelated to the privacy notice acknowledgement the patient is signing as part of the registration packet today. Let's look at why the Notice of Privacy Practices matters and how it fits into registration. Patients have a right to know how their information is used, and that right includes accessing records, amending them, requesting restrictions, and filing complaints. If they never receive the notice, they can't exercise any of these rights. The signed acknowledgement simply proves the practice made a good faith effort to inform them. Mechanically, the notice is given at the first encounter, usually inside the registration packet alongside billing forms like the assignment of benefits. The patient signs an acknowledgement confirming receipt, and that signed form gets filed in the chart while the patient keeps the printed notice. Exam writers love mixing this up with similar sounding forms. Assignment of benefits authorizes the insurer to pay the practice directly. Advance beneficiary notice warns Medicare patients about possible non-coverage. The OSHA Exposure Control Plan covers bloodborne pathogen safety, and a HIPAA authorization is needed only when disclosure goes beyond what's already permitted. When a STEM mentions a patient signing a privacy notice acknowledgement during registration, that's the Notice of Privacy Practices, not a billing form. Question 37. A consult letter describes that a patient lays supine on the table with the head of the bed elevated about 30 degrees during a procedure. The CMAA must select the matching position name when filing the report. Which positioning term best matches the brief description in the letter? Your options are A. Prone position with head down, B. Knee-chest position upright, C. Semi-fowler position, D. Sims position partial. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Semi-fowler position. C is correct because semi-fowler describes a supine position with the head of the bed elevated approximately 30 degrees, used for ease of breathing, comfort, and many bedside procedures where a low elevation is preferred. A is wrong because prone position with the head down does not match the supine arrangement described, and would generally describe a Trendelenburg or specialty surgical position used for very different clinical purposes. B is wrong because knee-chest position has the patient kneeling with the chest on the table, which is a different posture used for certain rectal or proctologic exams rather than a low elevation of the head. D is wrong because Sims is left lateral recumbent with the right knee flexed for rectal access, which is unrelated to the supine, head elevated position described in the consult letter being filed by the assistant. Semi-fowler position means the patient lies supine with the head of the bed raised about 30 degrees. It's used to ease breathing, boost comfort, and allow access for bedside procedures without fully sitting the patient up. These standardized terms exist because clinical communication needs precision. Instead of writing out the exact angle every time, saying semi-fowler conveys the same meaning instantly to anyone trained in positioning vocabulary, supporting clear handoffs, documentation, and patient education. Students often confuse semi-fowler with related terms, so contrast matters. Fowler raises the head 45 to 60 degrees, and high fowler goes to 80 or 90. Trendelenburg lowers the head below the feet. Reverse Trendelenburg raises it above the feet. and Sims is left lateral recumbent with the right knee flexed. Mechanically, staff position the patient supine and raise the head of the bed to the angle the position name specifies, with pillows supporting the head, arms, or legs as needed. Caregivers monitor skin, breathing comfort, and pressure points during longer holds, then document the position for the next caregiver. On exam day, watch for phrases like supine, head of bed elevated 30 degrees, and patient positioning, and match them to semi-Fowler rather than Fowler, Sims, or Trendelenburg. Question 38. A CMAA wants to invite a patient to describe a problem in her own words at the start of intake. The supervisor recommends a question type that cannot be answered with a simple yes or no. Which question type best matches this recommendation for opening the intake conversation? Your options are A. Closed-ended question for confirmation, B. Open-ended question for narrative, C. Leading question with a hint, D. Reflective question that mirrors back. Which would you go with? Lock it in before the reveal. The correct answer is B. Open-ended question for narrative. B is correct because open-ended questions invite narrative and cannot be answered yes or no, often beginning with what, how, or tell me, which gives the patient room to describe a concern in their own words and pace. A is wrong because closed-ended questions require short or yes, no answers and are useful for confirming specifics later, but they do not invite the narrative description the supervisor is recommending here. C is wrong because leading questions suggest an answer and bias the response, which the CMAA should avoid because they distort information rather than open the conversation to whatever the patient wants to share. D is wrong because reflective questions mirror the patient's words back to confirm and validate, which is helpful later in the conversation, but is not the opening tool that elicits a narrative description. Let's look at why intake conversations start with open-ended questions instead of yes or no questions. A question like, "What brings you in today?" hands the patient the microphone, giving them room to describe their concern in their own words and pace. Surfacing details a yes or no question would never uncover. The exam tests whether you can tell these apart. Open-ended invites narrative. Closed-ended confirms specifics. Reflective mirrors the patient's words back to confirm understanding. And leading questions suggest an answer, which biases the response and should be avoided. Picture a CMAA opening with, "What brings you in today?" The patient reveals back pain, sleep difficulty, and work stress, one detail leading to the next. And the CMAA then confirms specifics like onset and severity with closed-ended follow-ups. Remember, open-ended questions come first to invite breadth, and closed-ended questions follow to narrow in on specifics. Question 39. An imaging report describes a plane that vertically divides the body into right and left portions. The CMAA reads the report and confirms the plane name with the patient when answering a basic anatomy question after the visit. Which plane best matches this description in standard anatomical terminology? Your options are sagittal plane, B. transverse plane, C. frontal plane, D. oblique plane. Don't overthink it. Which one feels right? The correct answer is A. Sagittal plane. Is correct because the sagittal plane is a vertical plane that divides the body into right and left portions, with the mid-sagittal plane being exactly at the midline. Coronal divides front from back, and transverse separates top from bottom. B is wrong because the transverse plane is horizontal and divides the body into superior and inferior portions, the cross-sectional plane often seen in CT imaging rather than the right-left split described. C is wrong because the frontal or coronal plane is vertical, but divides the body into anterior and posterior portions, which is a different orientation than the right and left split described in the imaging report. D is wrong because an oblique plane is angled rather than aligned strictly with sagittal, frontal, or transverse orientations, and is not the standard plane that produces a clean right and left division of the body. Let's break down the sagittal plane and how it fits with the other anatomical planes you'll see on exam day. The sagittal plane is a vertical plane that divides the body into right and left portions. The mid-sagittal plane runs exactly along the midline, creating equal halves, while off-midline sagittal cuts still separate right from left, but produce unequal portions. Students often confuse the three standard planes. Sagittal divides right from left, coronal or frontal divides anterior from posterior, and transverse is horizontal, dividing superior from inferior. Oblique planes are angled and don't align with any of these. Imaging like MRI and CT produce sagittal slices exactly like this, showing vertical relationships between structures such as the spine, brain, and abdominal organs. On exam day, watch for the phrase vertical plane dividing right and left. That's your sagittal cue, distinct from coronal's front, back, and transverse's top-bottom division. Question 40. A physician submits professional services using a standard claim form, now primarily transmitted electronically as the 837P transaction. The CMAA recognizes the form. Which form best fits this professional claims tool, distinct from the institutional claims form used by hospitals in this kind of billing scenario today? Your options are A. UB4 form, B. 402, C. CMS 1500 form, D. Form 89. Got a guess? Lock it in. The correct answer is C, CMS 1500 form. C is correct because the CMS 1500 form is used for professional services such as physicians, NPs, PAs, and therapists, with the electronic equivalent being the 837P transaction submitted through clearinghouses to payers. A is wrong because the UB04 form is used for institutional claims such as hospitals, SNFs, home health, and hospice, with the electronic equivalent being the 837R transaction rather than the professional form. B is wrong because Form W2 reports wages and tax for employees, which is a tax form rather than a healthcare claim form used for professional services in the revenue cycle at the practice. D is wrong because Form I-9 verifies employment eligibility, which is an employment form rather than a healthcare claim form used for professional services in the revenue cycle at the practice today. Let's zoom out and understand why the CMS 1500 exists and how it fits into the bigger claims picture. Healthcare has two standardized claim forms. The CMS 1500 and its electronic version, the 837P, handle professional services from physicians, nurse practitioners, and therapists. The UB04 and its electronic counterpart handle institutional claims from hospitals, nursing facilities, and hospices. Mechanically, every professional claim carries the same core fields: patient demographics, insurance information, diagnoses, procedures with dates and units, charges, the rendering provider's national provider identifier, and billing provider information. The electronic 837P follows the same structure with extra metadata and validation. Picture a billing manager sending a batch of office visits, procedures, and injections as 837P transactions. The clearinghouse checks each claim against payer rules before forwarding it, and days later, 835 remittance advices report which claims were paid, pending, or denied, Don't confuse it with the UB04, a wage form or an eligibility form. When a STEM describes physician services and a standard professional claim, think CMS 1500 and its electronic partner, the 837P. Question 41. An auditor reviews documentation for office and other outpatient evaluation and management coding under the rules in effect since the 2021 update. The CMAA recognizes the new selection method. Which combination best fits the new selection method for the specific EM codes used by the practice today during ongoing reviews? Your options are A. Patient zip code only. B. Number of words spoken aloud. C. Average humidity in the room. D. Total time or medical decision making. Which one is it? Pause the video if you need more time. The correct answer is D. Total time or medical decision making. D is correct because office and outpatient codes are selected by total time on the date of encounter or by medical decision-making complexity following the major 2021 office and other outpatient code update. A is wrong because patient zip code is unrelated to EM code selection and is not part of the documented method for choosing the level of office and other outpatient codes under the current rules. B is wrong because the number of words spoken aloud is unrelated to EM code selection and is not part of the documented method for choosing office and other outpatient code levels under current rules. C is wrong because humidity in the room is unrelated to EM code selection and is not part of the documented method for choosing the level of office and other outpatient codes under current coding rules. In 2021, the rules for selecting office and outpatient evaluation and management codes changed dramatically. Instead of counting history and exam bullet points, clinicians now choose between two paths: total time or medical decision-making complexity. The update exists because the old framework had become a documentation burden that didn't reflect clinical reality. Providers wasted time chasing bullet counts, and auditors and providers frequently disagreed on levels, causing denials and frustration. Time-based selection counts all qualifying time on the date of the encounter, chart review, the face-to-face visit, documentation, ordering tests, consultant calls, and counseling. Medical decision-making complexity instead weighs the number and complexity of problems, the data reviewed, and the risk of complications, and the clinician picks whichever path supports the higher level. Picture an auditor reviewing a visit where the clinician documented 35 minutes total, including chart review, the visit, and order entry, while the medical decision-making shows moderate complexity. Both paths independently support a level 4 visit, so the auditor confirms the code without ever counting a single history or exam bullet. For office and outpatient EM codes, only two paths matter: total time on the date of encounter and medical decision-making complexity. Watch for distractors like zip codes or spoken words. They're never real selection criteria. Question 42. A new CMAA volunteers to interpret labs for a complex patient whose provider is running late. The supervisor steps in, recognizing a scope of practice concern. Which formal principle best explains why the supervisor intervenes in this kind of situation when patients are asking about their results? Your options are: A. Lab interpretation lies outside CMAA scope. B. Patients prefer faster answers always. C. Quick interpretation supports clinic flow. D. Providers cannot read results today. Take a second. Which answer would you pick? The correct answer is A. Lab interpretation lies outside CMAA scope. A is correct because lab interpretation lies outside the CMAA's scope of practice and belongs to the clinician, since results require clinical context, judgment, and treatment authority that administrative staff are not licensed to apply. B is wrong because patient preference for faster answers does not extend the CMAA scope, since speed cannot replace the clinical interpretation that protects safety and supports an accurate plan of care for the patient. C is wrong because shortcutting clinical interpretation to keep the schedule moving prioritizes flow over safety, which is the opposite of what scope rules and the practice's policy framework are designed to prevent. D is wrong because the assumption that providers cannot read results today is unsupported and not the underlying issue. The principle is about role boundaries rather than provider availability on a particular day at the clinic. A CMAA handles administrative and clerical work, but interpreting lab values, imaging reports, and other clinical results is explicitly outside that scope. Interpretation requires clinical context, judgment, and treatment authority that belong to the licensed clinician alone. A value that looks abnormal in isolation may be perfectly normal for one patient, or a stable-looking reading may actually signal decline given that patient's baseline. Only the clinician can weigh history, medications, and trends together to make that call. Mechanically, every result routes to the clinician for review and sign-off before release. The CMAA's role is administrative, scheduling a follow-up, delivering the clinician's written summary, or documenting a callback request, never stating what a value means. Scheduling, registration, message taking, and triage escalation using defined questions stay safely within scope. Interpreting lab results does not, no matter how busy the clinic gets or how much a patient pushes for a faster answer. The right response is always to acknowledge the request, explain that the clinician interprets results, and arrange for that communication to happen. This boundary exists to protect patients, not to slow down the clinic. Question 43. A practice uses a mental health screening questionnaire at intake for adult primary care patients. The CMAA recognizes a common standardized tool for depression screening. Which screening tool best fits a depression screen used by many practices in this kind of routine adult intake setting? Your options are A. Glasgow Coma Scale for trauma, B. APGAR for newborn assessment, C. PHQ-9 for depression severity, D. Snellen chart for vision testing. Before I reveal it, which one do you think is right? The correct answer is C. PHQ-9 for depression severity. C is correct because the PHQ-9 is a widely used standardized screening tool for depression severity in primary care, often paired with the PHQ-2 as a brief initial screen, and supports treatment decisions and monitoring across the care relationship. A is wrong because the Glasgow Coma Scale assesses level of consciousness in trauma patients, which is a different clinical purpose than depression screening at routine adult primary care intake during a regular visit. B is wrong because APGAR scores newborn assessment at 1 and 5 minutes after birth, which is unrelated to adult depression screening at primary care intake during a regular visit at the practice. D is wrong because the Snellen chart tests visual acuity at distance, which is unrelated to depression screening at primary care intake and serves a different clinical purpose during the assessment of a patient. Let's look at why the PHQ-9 exists and what makes it the right tool for depression screening in primary care. The PHQ-9 has 9 items tied directly to the diagnostic criteria for major depressive disorder, scored 0 to 3 based on frequency over the past 2 weeks. The total score, 0 to 27, maps to severity bands from minimal to severe, and the shorter PHQ-2 covers just the first 2 items as a quick initial screen. In practice, the PHQ-2 is given at intake and a positive result prompts the full PHQ-9. The patient completes it, a score is calculated, and the clinician reviews that score in context to decide on further evaluation, treatment, or referral, with repeat scores tracking progress over time. Exam writers often plant distractors that are real tools but serve different purposes. The Glasgow Coma Scale assesses consciousness and trauma. The UPGAR score evaluates newborns. The Snellen chart tests visual acuity, and the GAD-7 screens for anxiety, not depression. When you see routine adult screening for depression severity in a primary care STEM, think PHQ-9 with the PHQ-2 as its brief companion. Question 40. A patient cannot connect to a telehealth visit because the camera permission is blocked in her browser. The CMAA helps troubleshoot a common issue at the start of the encounter. Which step best fits accepted practice for this kind of patient-side technical problem during a telehealth visit setup? Your options are A. Cancel the visit, send later. B. Check browser permissions and restart device. C. Move the visit to inpatient observation. D. Charge a fee for telehealth troubleshooting. What's your answer? Commit to one before I continue. The correct answer is B. Check browser permissions and restart device. B is correct because common patient-side issues include camera permission blocks. The CMAA can have the patient check browser permissions, refresh, restart the device, or try a different browser before considering modality conversion to phone. A is wrong because cancelling the visit and sending a paper letter abandons the encounter rather than troubleshooting a routine issue that can usually be solved with a quick permission and refresh check. C is wrong because moving the visit to inpatient observation is a clinical decision unrelated to a routine browser permission problem. The modality issue does not change the appropriate care setting at all. D is wrong because charging a fee for telehealth troubleshooting is not standard practice and would discourage patients from completing the encounter, which conflicts with the support role the CMAA plays at this stage. Before a virtual visit can begin, the patient's device and connection have to actually work. When something goes wrong at the start, the CMAA's job is to troubleshoot first, not escalate. Blocked camera permissions, a muted microphone, weak Wi-Fi, and outdated or unfamiliar browsers are the usual culprits. These are simple, fixable problems, not reasons to cancel a visit. The CMAA walks through standard checks in order, confirming browser permissions, refreshing the page or restarting the device, and switching browsers if needed. This simple sequence resolves most issues in just a couple of minutes. Browser permissions live in the address bar or settings menu, where camera and microphone access are toggled per site. Refreshing reloads the app and often re-establishes that access, while restarting clears any software state that was blocking the connection. Routine troubleshooting is always the right first move for a patient-side technical issue. Only if the standard fixes fail does the visit convert to phone or get rescheduled. Question 45. A family medicine clinic adopts a hybrid approach. 2 patients at the top of an hour, then individuals at 20 and 40 minutes past the hour. The CMAA recognizes the hybrid pattern at work. Which scheduling type best fits this combination of wave and stream elements within a single hour? Your options are A. Pure stream scheduling, B. Pure wave scheduling, C. Block scheduling for procedures, D. Modified wave scheduling. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Modified wave scheduling. D is correct because modified wave scheduling combines wave and stream elements, often placing 2 patients at the top of an hour and individual patients later, which smooths flow while keeping useful structure in the calendar. A is wrong because pure stream scheduling assigns 1 patient per fixed interval throughout the hour rather than mixing a top of hour wave with later individual slots, so it does not match the hybrid pattern. B is wrong because pure wave scheduling assigns multiple patients to the same start time without later individual stream slots. So it differs from the modified wave pattern that includes both at different hour positions. C is wrong because block scheduling reserves time for a specific purpose like procedures or hospital follow-ups rather than mixing wave and stream within an hour for routine visits during the regular session. Modified wave scheduling blends wave and stream scheduling within a single hour, smoothing out the mid-hour rush while giving providers built-in recovery time. Pure stream schedules one patient per fixed interval, which cascades into delays when a visit runs long. Pure wave stacks multiple patients at once, absorbing variability but creating a chaotic waiting room burst. Modified wave splits the difference between the two. Mechanically, a 4-patient per hour clinic places 2 appointments at the top of the hour, then single slots at 20 and 40 minutes past. Staff room 1 wave patient while starting the second, and the provider staggers between rooms, absorbing short delays before reaching the later stream slots. Watch out for confusable concepts. Block scheduling reserves time for specific procedures. Cluster scheduling groups similar visit types together. And open access scheduling keeps the day open until the day of the visit. None of these describe the 2 at the top, then individuals pattern that uniquely marks modified wave. Whenever a stem describes 2 patients starting together, followed by individuals at set intervals, that combination points to modified wave scheduling, the hybrid built for uneven, real-world clinic flow. Question 46. A new patient is being registered. The CMAA collects legal name, preferred name, pronouns, date of birth, address, phone, email, emergency contact, primary insurance, and pharmacy. Which combination best fits accepted new patient registration data capture for this kind of new patient encounter at the front desk? Your options are A. Identity, demographics, insurance, contacts. B. Favorite color, pet name, birthday cake. C. Hometown news, sports stats, weather. D. Music preferences, vacation plans, films. Which would you go with? Lock it in before the reveal. The correct answer is A. Identity, demographics, insurance, contacts. A is correct because standard new patient registration captures identity, demographics, insurance, emergency contacts, pharmacy, and other elements that support clinical care, billing, communication, and population health analytics across the care relationship at the practice. B is wrong because favorite color, pet name, and birthday cake are not part of registration data capture. The practice focuses on identity, contact, insurance, and pharmacy details rather than personal preferences unrelated to clinical care. C is wrong because hometown news, sports stats, and weather are unrelated to clinical care and are not collected at registration, which focuses on identifying the patient and capturing the information needed to support the encounter. D is wrong because music preferences, vacation plans, and films are unrelated to clinical care and are not collected at registration, which focuses on identifying the patient and capturing information needed for the visit. New patient registration isn't just paperwork, it's a structured data set that lets a practice identify, communicate with, bill, and clinically care for a patient. Every field on the intake packet falls into one of 4 categories: identity, demographics, insurance, and contacts. Each category exists to serve a specific purpose, not just to fill space on a form. Identity supports correct charting and patient identification. Demographics support communication, accommodation, and reporting. Insurance supports eligibility and billing, while contacts support emergencies, family coordination, and pharmacy needs. Picture the completed packet itself: legal name, preferred name, pronouns and date of birth for identity, address and language preference for demographics, insurance and pharmacy details, and emergency contact information, all organized into these 4 sections. On exam day, if a data point doesn't support clinical care, billing, communication, or reporting, like a favorite color or vacation plans, it doesn't belong in registration. Stick to identity, demographics, insurance, and contacts. Question 47. A patient with TRICARE. Prime lives near a military treatment facility and asks the CMAA about the underlying network style of this plan compared to TRICARE Select. The CMAA recognizes the contrast in style. Which contrast best fits this comparison in the practices payer reference for the family today? Your options are A. Prime is PPO, Select is HMO style. B. Both are fee-for-service identical plans. C. Prime is HMO, Select is PPO. D. Both are workers' compensation plans. Don't overthink it. Which one feels right? The correct answer is C. Prime is HMO, Select is PPO. C is correct because TRICARE Prime is HMO style with a primary care manager and referrals, while TRICARE Select is PPO style with greater flexibility, and TRICARE for Life serves retirees with Medicare. A is wrong because this reverses the actual structure of TRICARE Prime and Select. Since Prime is the HMO style plan with a primary care manager and Select is the PPO style plan with greater flexibility. B is wrong because TRICARE plans are not identical fee-for-service arrangements. Prime and Select differ structurally, with Prime requiring a primary care manager and Select offering greater flexibility through a PPO style network. D is wrong because TRICARE plans are not workers' compensation plans. They cover military service members, retirees, and dependents through the Defense Health Agency rather than work injury benefits in the workers' compensation system. TRICARE is the health plan for active duty service members, retirees, and their families, run by the Defense Health Agency. Its 2 main plans, Prime and Select, mirror the classic HMO versus PPO distinction you see in commercial insurance. TRICARE Prime is HMO style, requiring a primary care manager to coordinate referrals to specialists, often through a military treatment facility. TRICARE Select is PPO style, giving greater flexibility to see network or out-of-network providers without referrals, though out-of-network care usually costs more. Mechanically, the front desk verifies the patient's exact plan at check-in, since billing and authorization rules differ. Prime patients typically need their primary care manager's referral for specialty visits. Select patients have direct access but face higher cost-sharing out-of-network, and TRICARE for Life beneficiaries follow Medicare's rules first, with TRICARE acting as secondary. Watch for exam traps. TRICARE Reserve Select covers reserve members not on active duty, while Veterans Affairs Care and Workers' Compensation are entirely separate systems from TRICARE. The key exam nuance is keeping Prime mapped to HMO style with its primary care manager and referrals, and Select mapped to PPO style with its greater freedom of choice. Question 48. A primary care office wants to integrate behavioral health for patients with depression. The team uses a registry, a behavioral healthcare manager, and a consulting psychiatrist who provides curbside guidance. Which evidence-based integration model is being described in this scenario? Your options are A. Patient-centered medical home, B. Collaborative care model, C. Accountable care organization, D. Concierge primary care. Got a guess? Lock it in! The correct answer is B. Collaborative care model. B is correct because the collaborative care model embeds behavioral health into primary care through a registry, a behavioral health care manager, and a consulting psychiatrist who provides curbside guidance, supported by specific monthly CMS billing codes. A is wrong because although a patient-centered medical home values behavioral health integration, its NCQA recognition rests on broader primary care attributes and not specifically on a registry-based psychiatric consultation staffing structure described above. C is wrong because an accountable care organization is a contracted network arrangement focused on shared savings and quality reporting, not a defined clinical model for embedding behavioral health staff inside a primary care team. D is wrong because concierge or direct primary care practices use flat membership fees rather than insurance billing, which has no connection to the registry-based behavioral health staffing arrangement described in the scenario. Traditional referrals often left patients stranded, screened positive for depression at primary care, then get told to call a separate behavioral health office. Many never followed through, and those who did waited weeks. The collaborative care model fixes this by embedding behavioral health directly into the primary care team. 3 roles define this model. The primary care provider screens patients and manages medications. The behavioral health care manager works directly with patients through brief interventions. And the consulting psychiatrist gives curbside guidance without ever seeing the patient directly. The mechanics center on the patient registry. The care manager repeatedly administers validated measures like the PHQ-9 and GAD-7, entering results into the registry, and the consulting psychiatrist reviews that registry weekly, offering recommendations back to the care manager and provider. Exam writers test whether you can distinguish this from lookalikes. The patient-centered medical home is broader team-based primary care recognized by accreditors. The accountable care organization is a shared savings contracting arrangement, and direct primary care runs on flat membership fees. The collaborative care model is specifically defined by its registry, care manager, and consulting psychiatrist. When a STEM describes a registry, a behavioral health care manager, and curbside psychiatric guidance, think collaborative care model. Question 49. A coroner contacts the practice to request information about a deceased patient as part of a death investigation. The CMAA recognizes the disclosure category and confirms the release with the privacy officer before sending. Which category of permitted disclosure best fits this request under HIPAA's framework here? Your options are A. Authorization required for marketing. B. Disclosure for self-promotion. C. Disclosure to friends only. D. Disclosure to coroners or examiners. Which one is it? Pause the video if you need more time. The correct answer is D. Disclosure to coroners or examiners. D is correct because HIPAA permits disclosure to coroners, medical examiners, and funeral directors for purposes related to identifying a deceased person, determining cause of death, or other duties as authorized by law without specific authorization. A is wrong because marketing always requires specific authorization, which is unrelated to the death investigation request from a coroner that this scenario describes for the purposes of an official inquiry. B is wrong because self-promotion is not a permitted disclosure category under HIPAA, since marketing requires specific authorization and does not fit a coroner's request for information related to a death investigation. C is wrong because disclosure to friends is not a defined permitted category under HIPAA. Family or friend disclosures are permitted with patient agreement or in best interest situations, not as a stand-in for coroner authority. HIPAA allows covered entities to disclose protected health information to coroners, medical examiners, and funeral directors without patient or personal representative authorization because the patient is deceased. This falls under the privacy rules permitted disclosures for specialized government functions and public interest activities. This category exists because death investigations, cause of death determinations, and funeral preparations all require medical information the deceased could no longer authorize themselves. Requiring formal authorization or court orders for every such request would impede legitimate public interest activities. Mechanically, a request arrives from a coroner or medical examiner. The privacy officer verifies identity and legal authority, and the disclosure is limited to the minimum necessary. The chart records the date, recipient, and purpose, sometimes alongside a separate audit log. Exam writers test whether you can distinguish this from confusable categories. Marketing requires patient authorization. Self-promotion isn't a permitted category at all, and disclosures to friends or family need patient agreement. Disclosure to coroners and medical examiners is its own distinct category for death investigation. When the STEM describes a deceased patient and a death investigation, match it to the coroner and medical examiner permitted disclosure category, not marketing, self-promotion, or family disclosure. Question 50. A practice's claim system requires the national provider identifier on every claim, both professional and institutional. The CMAA recognizes the underlying purpose of this identifier in billing. Which underlying purpose best fits the NPI in everyday claim submission at the practice? Your options are: A. Capture patient demographic data. B. Identify the provider on claims. C. Track inventory of supplies. D. Replace the diagnosis code. Take a second. Which answer would you pick? The correct answer is B. Identify the provider on claims. B is correct because the National Provider Identifier is a 10-digit identifier that identifies the provider on claims, with Type 1 for individuals and Type 2 for organizations, supporting accurate routing and adjudication across the claim submission process. L is wrong because the NPI does not capture patient demographic data, which is collected separately at registration and entered into the demographic fields of the claim, rather than into the provider identifier. C is wrong because the NPI does not track inventory of supplies, which is a different operational function handled through inventory management tools, rather than the claims provider identifier field at the practice. D is wrong because the NPI does not replace the diagnosis code, which is captured through ICD-10-CM and remains the diagnosis source on the claim alongside the provider's NPI for the encounter being billed today. The National Provider Identifier is a 10-digit number issued by the National Plan and Provider Enumeration System, used on claims and other high-pay standard transactions to identify who is providing and billing for care. Type 1 identifiers belong to individual clinicians like physicians, nurse practitioners, and dentists. Type 2 identifiers belong to organizations like group practices and hospitals. Both appear on claims to identify the rendering provider and the billing entity. Before 2007, providers juggled a different identifier for every payer, creating confusion and errors. The NPI replaced that patchwork with a single permanent identifier that follows the provider across payers, employers, and locations. Providers apply for an NPI through the enumeration system and keep it permanently. Every claim carries both the rendering providers and billing providers identifiers, and payers check these against their enrollment files to confirm the provider is authorized to bill. The NPI identifies the provider, not the patient's supplies or diagnosis. It's also distinct from the tax identification number used for taxes, the DEA number for prescribing controlled substances, state license numbers, and patient medical record numbers. Each serves its own separate purpose on a claim. And that's a wrap on today's CMAA question review. Want more practice on everything we just covered? Head over to our website You'll find the link right in the description below. Once you're there, you'll discover hundreds of free practice questions and complete study guides all ready and waiting for you whenever you're ready to dive in. Subscribe to catch the next part, and good luck on your exam.